thanks a lot for the excellent presentations, and I hope it will guide everybody to see what they will follow from tomorrow on for the ASH. Thanks a lot, Tariq, for the excellent moderation. I think we can proceed for the second session. And it's an honor for me to present the chairman for the second session, Dr. Naeem Chaudhri. Also, he's a very well-known figure and name in the field of the hematology. Dr. Chaudhri is a consultant hematology and bone marrow transplantation at King Faisal Specialist Hospital, Riyadh. He was elected recently as the president for the Eastern Mediterranean bone marrow transplant. He is a member of many society. He has a special interest in leukemia and bone marrow transplantation. He has many publications and in many peer-reviewed journals. So please, Dr. Naeem, he will be chairing our second session.
Welcome, everyone. Thank you very much, Amal. I just want to take this opportunity first to thank the organizers for SSBD, the only and the largest national society of Saudi Arabia for hematology and stem cell transplantation. And special thanks to Firas, and special thanks to Dr. Amal Behani for really the organizing this year. She's the chair of the organizing this time, and to put up such a great program. What we'll do in the next session is we have 4 talks primarily for the malignant hematology, mostly for acute leukemia, chronic leukemias, lymphoma, and bone marrow transplantation. I hope it will be a very fruitful session, and please write all your question and answer sessions. So all your question and answers. So in the end, we will answer. We have about 30 minutes to 35 minutes that will be given to discuss all the questions that you put on the Q&A icon on your screen. So please feel free to keep adding the questions to it. So let me introduce our panel today. We have 4 talks, and I will introduce every speaker for before the talk. We have acute leukemia, chronic myeloid leukemia, lymphoma, and bone marrow transplantation and cellular therapy. So our first presentation is Dr. Ryatov Fakih. He is an associate professor at Al Faisal University, which is a teaching, King Faisal is a teaching hospital for this university. He's also the head of the newly formed clinical research department at King Faisal Specialist Hospital and Research Center in Riyadh, which overlooks and will be doing coordinating for all the transplants, the prospective or the retrospective, any interventional trial will be done under the clinical research department. And we have the honor that the first head of this newly formed department is from our oncology center and from our section. Of course, Dr. Ryatov Fakih is also a consultant hematology and bone marrow transplant consultant with us. He has published a lot, and he is very much involved in significant research activities in the acute and chronic leukemias and lymphomas. He's also the PI of one of the SOLVE trials that is open and accruing patients. So Dr. Ryatov Fakih is going to talk about acute leukemias. Riyadh, the forum is yours.
Thank you, Dr. Chaudhri, and I would like to thank the organizers for inviting me to talk about acute leukemia and ASH 2020. So I did a quick search on the ASH website, and by searching for acute leukemia, I got 294 oral abstract. So I excluded transplant abstract and CAR T-cell abstract, ended up around 150 in the 150s abstract just regarding acute leukemias. So the first abstract I chose is the initial 1 trial, which may have some impact on our patient population. This is a phase 2 study evaluating inotuzumab as a frontline induction for ALL in elderly patients, defined as older than 55. So the way it was done, it was for Philadelphia negative ALL, more than 55 years old, having more than 20% CD22 expression, treatment naive, pre-phase of steroid was okay to recruit on that trial. So the way they did it, they did a first induction, which is 3 doses of inotuzumab, day 1, 8, and 15. Day 1 was 0.8, day 8 and 15, 0.5 milligram per meter square. along with dexamethasone, day 7 to 8 and day 14 to 7, and a triple IT. So basically, inotuzumab, dexa, and triple IT. The second and third induction was inotuzumab 0.5, day 1, 8, and 15, plus triple IT without steroids. And the response evaluation was done after each cycle. Patients in CR were offered to go onto conventional consolidation therapies. And these consolidation therapies were a little bit attenuated for this age group. So the consolidation consisted of intermediate dose methotrexate and asparaginase, intermediate dose RSC, and one reinduction with IDA, RSC, cyclophosphamide, and DEXA. Rituximab was added for CD20 positive ALL. And patients continuing on the treatment were allowed to go on a maintenance phase, which was mercaptopurine and methotrexate. The primary endpoint was event-free survival at 1 year, and the event was defined as persisting blast after 2 cycles of inotuzumab, relapse, or death. And they considered an event rate less than 40% as a promising result of this trial that necessitate further investment in this elderly population. So 31 patients were enrolled, and by the time the abstract was prepared, data on 29 was available. The median age was 64, so a pretty elderly population with Philadelphia negative ALL. Median CD22 expression was 70%. 2 patients stopped induction after 1 and 2 induction due to liver toxicity, but both were in complete remission after induction. All the other patients completed induction therapy and achieved CR or CRI after the first induction. MRD was available on 23 patients, and 17 out of these were MRD negative by PCR, which is 1 to 10 to power 5. 4 events were reported, and these consisted of 2 deaths in remission, 1 relapsed ALL in first year of treatment, and 1 relapsed in the second year. So with a median follow-up of around 242 days, the probability of overall survival at 1 year was 82% in this very high-risk population. 2 patients were transplanted and continue to be in remission. As far as side effects, the above grade 3 effects reported were mainly myelosuppression, leukopenia, anemia, and thrombocytopenia, as well as liver function elevation due to inotuzumab. So basically well-tolerated and very efficacious therapy that needs to be investigated in a larger trial in this elderly population. The second abstract about ALL I chose was about Philadelphia positive ALL. And this trial was evaluating ponatinib in addition to venetoclax and steroid in relapsed refractory Philadelphia positive. So this is a relapsed Philadelphia positive, not frontline. I would like to draw your attention here to this population. So as you see, all of them received prior transplant. All of them except 1 received ponatinib. All of them received blinatumomab except 1. 3 out of 6 has T315I mutation in addition to others. And it was a dose escalation study. So they started with 400 milligram of venetoclax, and with no reported toxicity, they escalated to 800 milligram. The basics of this study was because Philadelphia positive is highly dependent on BCL2 pathway for survival. So this is the idea of testing anti-BCL2 venetoclax, okay? And again, adults with relapsed refractory ALL, Philadelphia positive ALL, or transformed CML were eligible. They started with a high dose of ponatinib, 45 milligram. And then for patients achieving CR or CRI, the dose was reduced to 15, for patients to 30. For patients achieving complete metabolic or molecular remission, the dose was reduced to 15. And venetoclax was used daily, 400 milligram for level 1, and then escalated to 800 milligram. Dexamethasone was given 40 milligram daily on days 8 to 11. And these patients were given 8 ITs and rituximab for CD20 positive disease. So again, the dose of ponatinib was adjusted. 6 patients were enrolled by the time of reporting this abstract. And as you see, 3 patients achieved complete molecular remission, okay, despite this heavy pre-enrollment therapies, despite failing transplant and blina and ponatinib. Interestingly, all these patients were on the 800 milligram of venetoclax, and also interestingly, all of them did not carry the T315I mutation, okay? So all of them achieved complete molecular remission. So with a median follow-up of 8.6 months, the median overall survival was not reached, and the estimated 9-month overall survival was 60%. So this is very impressive for relapsed refractory Philadelphia positive after failing all these lines of treatment. Moving to AML, I chose 2 abstract, 2 or 3. The first one is the Aml M16 trial, and this trial is a phase 2 randomized double-blind study investigating sorafenib versus placebo in combination with intensive chemotherapy for patients treatment-naive FLT3 ITD mutated AML. So the basics of this study was the sub-analysis done in the SORAMEL trial. As you know, the SORAMEL trial was intensive chemo plus placebo versus sorafenib in a newly diagnosed adult patient with AML, and sorafenib was used regardless of the FLT3 status. 46 patients on that trial were FLT3 ITD mutated, and subgroup analysis in this subgroup indicated a trend toward improved overall survival with the addition of sorafenib. So on this trial, the Aml M16, they enrolled 99 adults with FLT3 ITD mutation. All were adult, 18 to 65, with an allelic ratio more than 0.5. The randomization was 2 to 1, 2 to sorafenib versus 1 placebo. And the drug was given from day 4 to 10 of induction, and with each consolidation cycle. Then after that, the maintenance was done with 28 days cycles of sorafenib versus placebo for 12 cycles for 1 year. Allogeneic transplant was allowed per investigator. However, the use of sorafenib or placebo was not allowed post-transplant, okay? And the primary endpoint was event-free survival without censoring for allo transplant. An event was defined as failure to achieve CR, CRI, relapse, or death. So the drug was very well tolerated, and they were able to deliver the therapy for the majority of patients. As you see here, 78% of the patients entering the consolidation were on sorafenib, and 79% of the patients entering maintenance were on sorafenib versus placebo. So it was they were able to squeeze in the treatment. The overall response rate was 91% in the sorafenib versus 94% in the placebo. And with a median overall follow-up of 25 months, there was no significant difference in EFS. So as you see on this slide, these are the results. As you see, no difference in EFS, OS. And again, this is a FLT3 ITD population. Okay, so all of these are FLT3 ITD mutated. And post-transplant, there was a trend to benefit from sorafenib, despite the fact they did not continue sorafenib post-transplant. It was not allowed. But here you can see the group where the addition of sorafenib was significant, and that was the group with an allelic ratio more than 0.7. As you see, this is the graph for sorafenib, and this was statistically significant. And this is for an allelic, a lower allelic ratio. As you see on the smaller graph, there was no benefit. So my second abstract in AML was CPX versus 3+7 in elderly. This is the final result of that trial. You're all aware about the preliminary result. So this is the 5-year results of this study. And as you know, CPX is a liposomal encapsulated daunorubicin and cytarabine in a 1 to 5 molar drug ratio. Patients were elderly, defined as 60 to 75 with a newly diagnosed high risk or secondary AML. And the median follow-up was 20.7 months on the first result of the trial, and that first report showed significant improvement in overall survival versus the conventional 7+3. And as far as safety, both were comparable. So this is the 5 years follow-up. And here we have 309 patients randomized. The overall survival and the CPX was higher, 21% versus 9%. And at 5 years was 18% versus 8%. So a significant overall survival benefit with this drug. This is a schematic view of the result. As you see, this is the survival. The purple curve is the CPX, and the yellow is the 7+3. And here, after transplant, also the benefit was seen in different age groups. So here they split the age group 60 to 69, the benefit was still there, and 70 to 75, the benefit was still there. So a pretty effective drug for this unfortunate population. Nowadays, we have the venetoclax combinations, and these need to be compared to this drug in this population to know what's the best one. The other trial I chose is the Dono double trial, and the Dono double is the double induction. So as you know, some programs do double induction, and this trial was checked to see if this practice is beneficial. So adult patient 18 to 65 were treated with 3 and 7, and day 15 bone marrow was done. If blast less than 5%, then they were randomized to a second cycle of induction versus consolidation therapy. The primary endpoint was CR/CRi after completion of induction, and secondary endpoints were relapse-free survival and overall survival. 624 patients received 3+7, and 298, around 300, 48%, had less than 5% at day 15, and they were randomized. The median age was 52, and 92% of these patients were de novo. 53% had the NPM1, 25 FLT3 ITD. So pretty much standard population, standard AML population in regards to age and mutational status. And as you see, the favorable and intermediate and adverse risk subgroups were 56, 34, and 10% respectively. And as you see here, there was no benefit. Okay, this is the red is the double induction, the blue is the single induction, p-value 0.12, and this is the overall survival, also no benefit. So basically, if you achieve remission by day 15, bone marrow and AML, there is no benefit of reinducing these patients. There are no talks today without COVID-19 reports, and this is the COVID-19 heme malignancy report from the ASH Research Collaborative Registry. So this is a registry that was started in April 2020 to report COVID-19 patients to this registry. 250 patients with blood cancers from 74 sites were recruited. 33% were acute leukemia, 27 non-Hodgkin, and 16% myeloma or amyloidosis. The most frequent symptom was 73%, cough was second, 67%, dyspnea and fatigue were 50 and 40%. A lot of people received hydroxychloroquine, azithromycin. The overall mortality was impressive, 28%. However, probably this is a biased report from reporting bias. You know, we tend not to report mild cases, or we don't know about these. But this is impressive, 28%. And patients with a physician estimated prognosis less than 12 months. So if the physician estimated their prognosis less than 12 months, and patient with relapsed refractory disease had the highest incidence of moderate to severe COVID-19 disease and the highest rate of death, as you see here in this schematic view. With this, I will finish, and thank you.
Thank you very much, Riad, for an excellent presentation on different aspects of acute leukemia. What we'll do is we'll move to the next speaker, Dr. Alabdulwahab. Dr. Amal from King Abdullah Medical City, consultant in hematology and stem cell transplantation. She's also Associate Executive Director of the Oncology Center. We all know her very well. She's very well known in malignant hematological disorders. And our colleague has a research interest in acute and chronic leukemias. The topic that she will discuss today will be chronic myeloid leukemia. Dr. Amal, you're online. You have about 15 minutes.
Can you hear me?
Yeah, now we can hear you.
Okay.
So you have 15 minutes, Amal. I already introduced you. Please go ahead.
Thanks for inviting me. And starting with a few abstracts regarding the CML. The first one is about asciminib, which is the first-in-class STAMP inhibitors, specific targeting the APL myristoyl pocket. The drug inhibits the tyrosine kinase activity of APL1 by targeting the APL myristoyl pocket on the kinase domain rather than the ATP binding pocket, which is targeted by all approved TKI. Starting with phase 1 trial, which include previously treated chronic myeloid patients harboring the T315I mutation, it reduced measured molecular response close to 60% at 24, 48, 72, and 96%, 96 weeks, with a nearly double the response in those who were ponatinib naive as compared to those who previously received ponatinib. And no on-treatment deaths were reported. Grade 3 or more adverse events were reported in 32% of patients, with main toxicity, GI, bone marrow suppression, and allergy. Moving to a phase 3 trial, which was among the late-breaking abstract, it was compared with asciminib to bosutinib in CML patients who were previously treated with 2 or more tyrosine kinase inhibitors. So patients were stratified by major cytogenetic response at a baseline, with the primary endpoint, major molecular response rate at 24 weeks. And the patients who failed bosutinib were permitted to switch to asciminib arm. Patient characteristics are shown in this table, and few discrepancies were in the number of prior lines of TKI and the reason to discontinue the previous TKI in the range of 10%. The most common reason for treatment discontinuation was lack of efficacy, 21% in asciminib arm and bosutinib 31%. And most of patients who discontinue bosutinib due to lack of efficacy were switched to asciminib. So for the whole patient group, the median duration of follow-up was 14.9 months from randomization to cutoff. Asciminib showed higher major molecular response, 25 versus 13, and complete cytogenetic response, 40 versus 24. It also showed a higher MR4 and MR5 as compared to bosutinib, and the time to achieve MMR was shorter with the asciminib arm, 12.7 versus 14. And the pre-planned subgroup analysis showed that MMR rate at 24 weeks was superior with asciminib than bosutinib across most major demographic and prognostic subgroup, including in patients who receive more than 2 prior TKI and those who discontinued the prior TKI due to treatment failure, and regardless of baseline cytogenetic response, apart from those with BCR-ABL less than 1% did better with the bosutinib arm. Bosutinib was associated with higher overall and grade 3 or more adverse event. Adverse event require dose interruption and or adjustment or treatment discontinuation with bosutinib R. And more grade 3 thrombocytopenia, 17 versus 6.6, and neutropenia, 14.7 versus 11.8 with asciminib R. On treatment, death occur in 2 patients on asciminib, one with ischemic stroke and one with arterial embolism, and 1 patient on bosutinib due to septic shock. Next abstract about 5-year update of the Endpoint trial that tested the TFR following second-line nilotinib. TFR rate at 5-year was 42, and MR 4.5 at 5-year after starting TFR was 37. Nilotinib was reinitiated upon loss of MMR or loss of MR 4.5. So nearly 47% of those patients resumed treatment and achieved MMR 98%, and MR 95, MR 4.5 93, which was faster if the treatment initiated with confirmed loss of MR4 2 months compared with loss of MMR for 3.6 months. There were no case of disease progression or death due to underlying CML. Withdrawal symptoms were higher in the first year and then become lower later on. In patients who resumed nilotinib, the rate of all grade adverse event was higher, 94, than during consolidation, 77%, with the most common adverse event being hypertension, arthralgia, constipation, and hyperglycemia when reinitiating nilotinib. Next abstract, the Italian group highlighted the importance of karyotyping and the effect of complex variant translocation on response to first-line TKI. They identified the complex variant translocation in 109 patients from a whole population, 3,361 subjects with a newly diagnosed CML. 95 out of 109 patients exhibit translocation with chromosomal 1, 4, 6, 10, 11, 12, 14, 15, and 17, representing the most common additional partner. Patients with complex variant translocation involving chromosome 1, 4, 6, 11, or 12 had higher frequency of MMR at 12 months than patients with the complex variant translocation involving 10, 14, 15, or 17. 75 versus 30%, and this was statistically significant. Higher frequency of stable deep molecular response, 48 versus 22, and tended to have a better median failure-free survival, regardless of the type of frontline TKI and of ELTS score. In this trial, the ECOG is exploring a new paradigm of treatment CML based on animal studies that shown involvement of T cell in the interaction with CML cells. So in this trial, the study whether adding anti-PD-1 pembrolizumab to TKI is safe, increase the rate of conversion to undetectable measurable residual disease, and allow a higher rate of TKI discontinuation. Pembrolizumab therapy is used in CML patients on first, second, or third line TKI therapy who did not achieve undetectable MRD. And the study scheme shown in the figure, a result is still awaited. Finally, there is 5-year update of B4 trials, which compare bosutinib versus imatinib as a first-line treatment in CML patients. And the MMR, MR4, MR4.5 were all higher with bosutinib. 4-year duration of response and 5-year survival were similar in both groups. However, the most common reason for permanent discontinuation were adverse events, 25 versus 12.5%, and lack of efficacy, 4.9 versus 16%. On treatment transformation to accelerated or blast phase, there were 6 patients in bosutinib arm and 7 patients in imatinib arm. So to conclude, asciminib, first-in-class STAMP inhibitor, demonstrated statistical significance and clinically meaningful superiority in efficacy compared with bosutinib, deeper MR rate, and favorable safety profile in a patient with CML, whether chronic phase or accelerated phase, and CML harboring T315I, including those who failed ponatinib. Following second-line nilotinib, TFR is durable and safe in patients with the CML chronic phase. Majority of patients requiring nilotinib retreatment rapidly regaining MMR, MR4, or MR4.5. The Italian study reinforced the usefulness of bone marrow karyotyping in CML. Immunotherapy may further enhance the action of TKI in CML. So we're waiting to see the result of that study. At 5 years, first-line bosutinib continued to show superior efficacy versus imatinib regarding molecular response, particularly patients with high SOCL score, but not change in event-free survival or overall survival. Thank you.
Thank you very much, Dr. Amal. I think we'll move to our next. Thank you for the presentation of important abstracts for chronic myeloid leukemia. What we'll do is now we'll go to the next topic on our agenda, which is some important abstracts on lymphoma by Dr. Moussab Damlaj. And I would like to introduce Dr. Moussab Damlaj. He is Associate Professor of Medicine and Hematology at King Saud bin Abdulaziz University of Health Sciences. He's also a consultant adult hematology stem cell transplantation in the Department of Oncology at King Abdulaziz Medical City. He's very well known, he's a colleague, and he's presented in a lot of our conferences. Dr. Moussab Damlaj, please, the forum is yours for 15 minutes. You'll be talking about lymphoma. Thank you.
Thank you, Dr. Naeem, for your kind invitation and for the SSBT for inviting me to speak with you today. I was asked to talk to you today about lymphoma and CLL updates from ASH. The abstracts that I chose were abstracts that I think may have the potential to be practice changing either in the near or distant future. So I have 2 abstracts in CLL and 5 abstracts in lymphoma, so we'll try my best to stick to the time. The first abstract is an update on the Murano trial, which was initially published 2 years ago at ASH and then followed up by a New England Journal of Medicine publication. Just as a quick reminder, this was the randomized phase 3 that compared bendamustine rituximab to venetoclax rituximab with an endpoint primarily being PFS. So this was an updated analysis looking primarily at MRD data and at the 5-year median follow-up. As you see, the PFS was significantly better in favor of venetoclax rituximab. Now, at the 5-year mark, the PFS benefit was sustained, as this is a not surprising finding. The median PFS was 53 for venetoclax compared to 17 months for bendamustine rituximab. And here, the main focus of this report is on the MRD rate. So the unmeasured or MRD negative rate was seen in 83 out of 118 evaluable patients, reflecting about 70%, so a very respectable number. However, what is also most interesting for us is what's also called the treatment-free remission. So in other words, how sustained is this MRD negative rate over time? And what we observed here with longer follow-up at 5 years is that the MRD conversion was seen in 47 of those 83 patients, so reflecting about 50 to 60% MRD conversion. The median conversion time happened at around 19 months. So this gives us also an idea of how long we need to follow these patients before we start to see some MRD re-emergence. And keep in mind that those are relapse refractory patients. So this, in theory, may happen later on for patients treated in the front line. Factors associated with recurrence of MRD was unmutated immunoglobulin status, deletion 17p, complex cytogenetics, essentially referred to as 3 or more cytogenetic aberrations. So these are classically conventional risk factors. They did a landmark analysis also, and what was observed is that patients that have MRD conversion have a worse overall survival, although you see that the difference between the two groups was relatively small. So in conclusion, promising rates of MRD negativity, about 40 to 50% of this MRD negativity is sustained beyond 5 years, which is quite impressive, keeping in mind that these are relapse refractory patients. The next abstract in CLL also pertains to treatment-free remission. This is the theme that many of us are interested in because it may reflect on how we view the treatment paradigm in CLL. This was a phase 2 multi-center trial, the Captivate trial by Professor Riad from the MD Anderson. Frontline treatment of venetoclax ibrutinib. If you remember, there was an earlier trial by Professor Jain, also frontline ibrutinib venetoclax trial. Here, just to remind you, essentially the treatment protocol consisted of 3 cycles of ibrutinib to decrease the risk of tumor lysis syndrome, followed by 12 cycles of ibrutinib venetoclax. Looking at the MRD rate, which was previously published, the MRD rate was 75% in peripheral blood, 72% in bone marrow, so roughly about 70–75%. And then what we're looking at, what this report focused on was the treatment-free remission in the setting of this negative MRD. So MRD was measured serially. Patients that were MRD negative or UMRD were randomized to ibrutinib versus placebo. And then patients that had detectable MRD were randomized to ibrutinib or ibrutinib venetoclax. So you see a relatively small number of patients and then split over a number of groups. So this dilutes the overall message, as we will see. Primary endpoint was 1-year disease-free survival, and you can argue whether this is long enough or not. So 164 patients in total, the median age was 58. These are the high-risk features. You see that they were reasonably prevalent. So unmutated immunoglobulin mutation in 60%, deletion 17p in about 20%, deletion 11q in 17%. The rate of MRD negativity was 58% in the entire cohort. These patients were then randomized to placebo versus ibrutinib, and the remaining 42% were randomized to ibrutinib or the combination of ibrutinib and venetoclax. As you see in the unmeasured or MRD negative group, randomization to either ibrutinib or placebo has not changed the disease-free survival rate at the 1-year mark. So it's 95% compared to 100%. The numbers are excellent, as you can see. But then again, reflecting on the previous Murano abstract in the relapse refractory setting, you see that the median time to MRD conversion was 19 months, and it's probably longer in the frontline setting. So you can argue that you need a more mature follow-up to really conclude whether continuing on ibrutinib is really helpful or not. Although you can also argue that ibrutinib continuation defeats the whole purpose of treatment-free remission, and it becomes very similar to treating until progression. You look at the PFS rate by randomization. Again, as you see in the box further down, you see that the groups have become diluted. So the 160 patients were again essentially split into 30 to 40 patient groups. And then here the statistical significance becomes harder to prove. But I think the important message is that more mature follow-up is needed, and in general, excellent rates of MRD negativity. And we really need to see whether this, what's the proportion of these patients that remain MRD negative over time. So now switching over to lymphoma, the first one, and I apologize if this overlaps with Dr. Alzahrani's presentation. Dr. Zayed's presentation, excuse me. This is allogeneic transplant in mature T-cell lymphoma. This was a retrospective multi-center study across 12 US centers by Professor Meera Shah, who is a known T-cell expert. This looked at allogeneic transplant in the setting of T-cell lymphoma. The median age was 51. Transplant indication was about 70% relapse refractory. Surprisingly, 24%, even though it was a retrospective study, they did not specify the indication for transplant. About half of the patients were in complete remission, and then the remaining were in either partial or 8% were in stable or progressive disease. Surprisingly, only 15% of patients had a prior autologous transplant. At least I would have thought that the majority of those patients would have had a transplant initially prior to the allogeneic transplant, either as part of consolidation or at first relapse, but majority did not. As you can see, different histologies were represented from the PTCL NOS to angioimmunoblastic, the ALK positive and negative. In fact, even more rare subtypes such as the primary cutaneous gamma delta T-cell lymphoma, I've only seen a couple of cases of those before. 6 of them underwent an allogeneic transplant. I think the message here, if you look at the PFS and OS survival curves on the right, is that the outcome is really excellent in this high-risk group of patients. And if you look at in the table, the 2-year PFS ranged anywhere between 55% to as low as 33%. And for this type of disease, I think this is a very respectable number. So the conclusion from this is that allogeneic transplant should certainly be considered in patients that are fit and are eligible to proceed. And it represents a reasonable treatment option, particularly in this disease where short of brentuximab, where things have improved a little bit, there has been really very little that has changed the landscape in this high-risk disease. The next abstract looked at consolidation using nivolumab, brentuximab in patients that were deemed high risk after autologous transplant. This builds up on the Athera trial, which was, as you know, was published a few years back, I think 5 or 6 years ago now, where brentuximab was given as consolidation for up to 16 cycles in patients that are brentuximab naive. Here, what they did is they did what's so-called modified Athera criteria. So they used the primary refractory, the 1-year relapse, extranodal disease or B symptoms, but then they added to it patients that require more than 1 line of salvage and patients that are not in CR at the time of transplant. And these are what I call real life risk factors that many of us extrapolated from the Athera trial and used brentuximab for these 2 indications. The other thing is that these patients, was a multi-center phase 2, and these patients were not being brentuximab or nivolumab naive was not mandatory. So some of those patients have received such prior therapy before. The dose schedule was as such, so BV standard dose, 1.8 per kilo every 3 weeks, nivolumab 3 milligram per kilo every 3 weeks, a total of 8 cycles of therapy. So patients would get about 6 months of treatment compared to the 1-year conventional Athera protocol. The primary endpoint was 18 months PFS. This was felt to be long enough to detect the majority of events, mainly relapses that usually are seen relatively early post-transplant in this high group of patients. They've treated 60 patients, and then you see a third had 1 risk factor, but then 40% had 2, and then a quarter of those patients had 3 or more risk factors. And as you remember from the Athera trial, the benefit of consolidation increases with the number of risk factors. These are the baseline characteristics of the patients. It's important to note that complete response was noted in 80% patients. The frontline treatment majority received ABVD or minus bleomycin in some of them. Beam was the most common conditioning regimen that was used. Prior brentuximab was given in 50% of patients, so half of them received brentuximab, 42% received checkpoint inhibitor prior to transplant. If you look at the PFS curve, the blue one on the right, a very respectable number, so 95%, so almost no events at the 18-month mark. In fact, this extends even beyond that. I think this, obviously we cannot do a cross comparison, is not generally recommended, but this is a very impressive outcome. Obviously the limitation of this being a relatively smaller number and the follow-up would be nice if it was a little bit longer, but very impressive. I think this potentially could be practice changing. And the next abstract that I wanted to discuss is the so-called ZUMA-5 and using axi-cell in relapse refractory indolent non-Hodgkin's lymphoma. So this is predominantly using CAR T-cell therapy, the Yescarta product, in patients with follicular lymphoma or marginal zone lymphoma. This was a phase 2 multi-center trial. These are patients that have received 2 prior lines of therapy, which incorporated the use of anti-CD20. A total of 146 patients, mainly follicular lymphoma, but some marginal zone. The primary endpoint was the response rate by central review. As you see, the median age is generally older, 61, with patients being treated up to age of 79. Majority had stage 3 and 4. Median was 3 lines of therapy, and more than 2/3 of them were refractory to the last line of treatment. If you see the progression of disease within 24 months, seen in more than half of the patients in follicular lymphoma, and to me, this is a very bad prognostic sign. So here, as you see, they're recruiting high-risk patients. The median follow-up was almost 18 months. The overall response rate was 92% in patients that had evaluable efficacy. So those were 104. Almost 3/4 of them were CRs. And these responses were comparable across different risk factors. So looking at FLIPI, POD24, GELF, refractory, etc. Adverse events were noted as expected, but the ones that concern us is the CRS. Grade 3 of this was only seen in 7%, neurologic events, grade 3 in 19%. They measured peak CAR T levels and they correlated with activity. So patients that had higher levels had higher ongoing responses. So this looked at the use of high-dose methotrexate for CNS prophylaxis in DLBCL, very debatable topic. I remember this discussion for more than 10 years. We debate which is whether to use high-dose methotrexate or not. This was a retrospective analysis from 2 centers in Alberta, Canada, almost 1,000 patients, follow-up of 35 months. They used the prophylaxis of high-dose methotrexate 3.5 grams after 2, 4, and 6 cycles of R-CHOP. Or R-CHOP-like, and their indication changed over time. So in the earlier phases, 2012 to 2015, they used elevated LDH ECOG of more than 1 or more than one extranodal site. And then after 2015, they relied on the CNS IPI, double hit, or testicular lymphoma, and they looked at the CNS relapse incidence. As you see here with the curve on the right, the cumulative incidence, you see that patients that have a higher CNS IPI have a higher risk of CNS relapse. This is not surprising. They looked at risk factors for CNS relapse, which essentially was the APL-CGP, high risk CNS IPI, and testicular involvement, or all had a risk hazard ratio of about 3 to 4. But it was most interesting to me was that the CNS relapse rate was 11% versus 12% in patients that were deemed high risk or not. So in other words, the incidence of CNS relapse was essentially the same whether high risk methotrexate was used or not. What was not clear from this abstract was whether other form of CNS prophylaxis, so IT, was used in the patients that were felt to be high risk. But this will become clear hopefully with the oral presentation. But again, I think as more and more evidence accumulates that high-dose methotrexate probably does not protect us in the era of rituximab, we may be shunning away from it, particularly with the higher incidence of renal toxicity and other toxicity that we can see. There's another abstract across the US, multi-center, I think it was 12 centers across the US that had a similar conclusion to this. I had one more abstract, but I think we will call it quits. And I thank you for your attention. And if you have any questions, I'll be happy to take them in the end.
Thank you very much. So we'll have some time for the discussion also at the end, so some of these things can be rediscussed again. So what we'll do is we'll move to the next topic, and this time this will be the bone marrow transplantation and cellular therapy. This will be by Dr. Zayed Alzahrani. Dr. Zayed Alzahrani is a program director of Adult Hematology and Fellowship Training Program Director as well for Adult Stem Cell Transplant Program at King Faisal Specialist Hospital and Research Center in Jeddah. He is also a consultant in Adult Hematology and Stem Cell Transplantation of the Department of Oncology. He has special interest in transplantation as well as treatment of malignant hematological disorders.
Thank you, Dr. Chaudhri, for this introduction. And thank you for the organizer, really, for this very excited and very enjoyable discussion about all the topics that have been presented. Really, I enjoyed it. And this is the last session that will be presented, has been asked to talk about bone marrow transplantation and cellular therapy. So the first abstract that I'm going to talk about the comparison of the outcome after haplotransplant with unrelated donor transplant with the use of BTCY as a GVHD prophylaxis. The introduction, the relative value of matched unrelated transplant versus haplotransplant in the context of BTCY is not known. And this studies will compare both haplo and unrelated transplant with the use of BTCY as a prophylaxis, GVHD prophylaxis. This study is using the eligible patient more than 18 years and receive haplotransplant or unrelated transplant for AML or ALL or MDS in the US for at least 7 years. Patient receive either myeloablative and or reduced intensity transplant, and the GVHD prophylaxis for the myeloablative transplant was BTCY and calcineurin inhibitor and MMF. For the myeloablative, was 55% they used the BTCY and MMF, and 45% BTCY and calcineurin inhibitors. Next. So myeloablative conditioning, the predominant myeloablative conditioning was the use of the TBI fludarabine fully ablative transplant for haplo, and use for unrelated transplant is the TBF in 59%. And regarding the reduced intensity conditioning, the predominant conditioning regimen was flucide TBI in 88%, which is, I'm doubting this is reduced intensity. This is non-myeloablative transplant. So this is being considered under reduced intensity transplant. And for unrelated transplant, flucide TBI 37% and fludarabine melphalan 33%. Next. So the result for the myeloablative conditioning regimen, the engraftment was equal, and the risk of GVHD grade 3 and 4, the acute and chronic, there was no difference, and non-relapse mortality and relapse disease-free survival and overall survival did not differ between the treatment group. However, in the reduced intensity transplant, the engraftment was equal, and the risk of GVHD was did not differ between the two groups. However, the non-relapse mortality was lower after match unrelated donor, which led to the higher disease-free survival and overall survival for those patients with treated transplanted with match unrelated. Next slide. So this is it. Show you in the graph and the figure that showed if using myeloablative transplant, there is no difference between unrelated or haplotransplant with the use of BTCY. However, if you use the reduced intensity conditioning, there is some improvement of the use myeloablative, the reduced intensity unrelated transplant comparing to the haplo with the use of BTCY. Next slide. So in conclusion of this trial, that in patients who receive myeloablative conditioning with BTCY, calcineurin inhibitor, MMF prophylaxis, the haplo and unrelated transplant, they are comparable. However, in patients who receive less intense conditioning regimen, disease-free survival and overall survival after match unrelated, it was better for comparing to the haplo transplant. Next slide. The next slide, the next presentation will be the impact of cellular of origin on the long-term outcome post-autologous transplant for diffuse large relapsed refractory transplant, relapsed refractory diffuse large B-cell lymphoma. So the gene expression profiling had identified some of the genetic signature for the diffuse large B-cell lymphoma to 3 subtypes, ABC, GCB, and 3 subtypes. And we know that the GCB type had a favorable outcome comparing to the GCB, non-GCB type. this study is asking the questions whether the cell of origin retain its prognostic significance post-auto transplant in patients with relapsed refractory diffuse large B-cell lymphoma. It will answer these questions. Next slide. So it's a retrospective data carrying at Mayo Clinic database across all the 3 sites. It included up to age of 75 were diagnosed with de novo diffuse large B-cell lymphoma that he went under first the autologous transplant. Patient who received salvage therapy should be chemosensitive, otherwise will not be included in the trial. The primary endpoint include overall survivor, relapse, and relapse-free survival. Result: the 5-year-old survival for GCB patient versus non-GCB, it was 44 versus 64 with a significant p-value. The relapse rate is higher with GCB type, and the relapse-free survival was lower with the GCB type. So in conclusion, if you see this is the Kaplan-Meier diagram presentation, it shows that the non-GCB type, they have good outcome comparing to those non-GCB type, and the patient demographic, these are showing you that there is no difference between the selection of the patient. In conclusion, next slide. In this analysis, it's GCB diffuse large B-cell lymphoma result in worse overall survival, high relapse versus non-GCB type following autologous transplant. This is very strange data or result, but it's I'm waiting to see it in the oral presentation, and they comment about the GCB type may alter their natural history into more aggressive type post-transplant. The third abstract is the comparison of the reduced intensity conditioning allo and O2 for elderly patient acute lymphoblastic leukemia, and this is from the acute leukemia working party in the ABMT group. We know that the outcome of the patient of AL above age of 55, they are poor outcome. And those patients, they are usually not candidate for fully ablative transplant, so they are elected either to continue the chemotherapy or to go for reduced intensity transplant or to go for autologous transplant. So the goal of the study was to analyze the result of this transplant option and to identify factors affecting the outcome. Next slide. So 560 patients with ALL treated in the first complete remission with the reduced intensity transplant versus autologous transplant 142 between 2000 and 2018 was included in the study. Among the allogenic donor, 50% were HLA matched donor and 50% with match unrelated donor. The median age for reduced intensity transplant was around 60 in both O2 and ALLO. And the proportion of Philadelphia positive was 71% and 63% respectively. The measurable MRD positive result at the time of the transplant was reported in 35% and 21% respectively. The common use of the reduced intensity transplant is the busulfan fludarabine, the most used in regimen, while the combination of the 12-grade TBI and cyclophosphamide was the most frequent use in the autologous transplant. The result, of course, the non-relapse mortality, it will be higher with those patients they have reduced intensity transplant. However, the relapse incidence, the leukemia-free survival, and overall survival does not differ between the group. So in conclusion, the result of the auto transplant for patients with ALL is above age of 55 with MRD negative pre-transplant are encouraging, and this option may be alternative to reduced intensity transplant, which is associated with more non-relapse mortality, and it will improve the overall survival comparing to the match unrelated donor. The fourth abstract is the severity of the Thiotiba-containing conditioning regimen for primary diffuse large B-cell lymphoma of the CNS undergoing autologous transplant. The primary diffuse large B-cell lymphoma is a rare extranodal non-Hodgkin lymphoma with high-risk relapse without consolidation therapy. The autologous transplant has been the most common consolidation therapy for those patients with primary CNS lymphoma. However, the study defining the optimal conditioning regimen for primary CNS lymphoma has not been performed. The two common conditioning regimen has been used, the Thiotiba-based regimen with the use of the Thiotiba, busulfan, cyclophosphamide, and Thiotiba carmustine. And the comparative between those arm has been very slim. It's not been comparing between. It was not compared between both of them. The beam has been used and been considered for primary cell lymphoma in the US. Method. Next slide. The 608 adult primary CNS lymphoma patients underwent first autologous transplant, conditioning regimen TBC, and 265, Thiotiba, carmustine 278, and beam and 65. The primary endpoint was progression-free survival. Secondary endpoint was time to hemolytic recovery, relapse progression, non-relapse mortality, and overall survival. So you can see from the Kaplan-Meier that the progression-free survival are equal with the use of Thiotiba-based therapy, either Thiotiba, cyclophosphamide, and busulfan versus Thiotiba, carmustine. However, there is dismal outcome with the use of beam, and also being translated in the overall survival, with equal if you use Thiotiba-based comparing to if you use beam. And the conclusion from this PSI-BMTR analysis in a patient with primary CNS lymphoma, the favorable outcome with the Thiotiba conditioning regimen, and the beam it should be discouraged in this specific setting. Whether TBC or Thiotiba carmustine is the optimal conditioning regimen required further inquiry in a prospective clinical trial. Before the last abstract, the allogeneic transplant versus no transplant in adult patient Philadelphia chromosome positive ALL and complete molecular remission. So we know that until this point, the allogeneic stem cell transplant and the first complete remission is the standard of care for adult patient with Philadelphia positive ALL. The addition of the TKI has been resulted in a significant higher rate of complete molecular remission and better overall outcome. However, the given increased toxicity associated with transplant, we aim to study to benefit for those patients Philadelphia positive and to test those patients in Philadelphia ALL and CR1 in complete molecular remission. Next slide. So it was multi-institution retrospective analysis of 186 patients who received induction therapy with TKI for Philadelphia positive ALL from January 2001 to December 2019, who achieved complete molecular remission in CR1. Patients that achieved complete molecular remission within 3-month diagnosis were included, and 66 patients underwent transplant, and 120 patients did not receive transplant, and they are in the non-transplant group. The primary outcome of interest were overall survival, relapse-free survival, and cumulative incidence of relapse, non-relapse mortality, and GVHD-free, relapse-free survival. And in this Kaplan-Meier curve, it showed there is the overall survival, relapse-free survival was equal between the two groups. However, the relapse was higher in those patients they continuing chemotherapy without transplant, but the toxicity from the allogenic transplant is associated with higher gravis. So the conclusion from this trial, this multi-centric retrospective study showed that the adult patients with Philadelphia positive ALL and complete molecular response have similar estimated overall survival, relapse-free survival, lower cumulative incidence of relapse in the transplant group was offset by the higher non-relapse mortality, resulting in the similar relapse-free survival. Result of this study need to be confirmed in prospective trial. The last trial is the upfront alternative donor transplant versus immunosuppression therapy in the patient with aplastic anemia who lack HLA matched donor. This is meta-analysis prospective study on behalf of the severe aplastic leukemia working party, the ABMT group. Until now, we know the standard treatment strategy for severe aplastic anemia for children and adult younger than age of 40 is the transplant from matched sibling donor. And the immunosuppressive therapy is the main treatment for those patients above the age of 40 or those patients they didn't have matched sibling donor. The response rate of immunosuppressive therapy is around 40%, 70%. And many patients suffer from relapse or clonal evolution, and the use of alternative donor transplant from matched unrelated donor or HLA haploidentical is not commonly used in frontline setting. This systematic review of, and meta-analysis retrospective study to compare the outcome of immunosuppressive therapy versus alternative donor transplant as upfront therapy of severe aplastic anemia. Next slide. So you can see that the all-or survival in the upfront using alternative donor transplant versus immunosuppressive therapy favoring the alternative donor transplant in the very upfront setting, and also in the salvage setting, favoring the use of alternative donor transplant and comparing to the immunosuppressive therapy. So in conclusion, this study showed the potential survival advantage of upfront alternative donor transplant over immunosuppressive therapy in a patient with severe aplastic anemia who lack an HLA identical sibling donor. The use of alternative donor transplant earlier in the disease course rather than the salvage in the young patient with severe disease may improve survival. By this, I conclude. Thank you very much for your listening.
Thank you very much for all the panelists who presented excellent abstracts today for the second session of our ASH perspective. The panelists can just turn their videos on and and unmute themselves if they want to. So we can go to the questions. We have certain number of questions that can be that have been asked by the attendees, and also let me ask those questions first, and then what we can do is, because we have time, we can let the audience join in by unmuting themselves. We can allow them. They need to keep themselves mute, and if somebody wants to ask a question, they have to present themselves or introduce themselves and then ask a question. So let me go to the first. There are a few questions that I wrote down, and I got some just from what was written on the Q&A thing in the question and answer sessions. For Dr. Ryad, where do you see incorporation of itolizumab in clinical practice? Certainly Similac or the nilotinib. There was one question where people are asking, does the karyotyping get diagnosis or is it a follow-up also? Dr. Amal, do they recommend that? Was that importance of karyotyping done at the diagnosis or on routine follow-up?
So this was actually an observation.
Okay.
It wasn't a randomized control. but it was an observational study, and they found the chromosome, certain chromosomes associated with poor outcome rather than others. So that study encouraging people when they diagnose a chronic myeloid leukemia to check for the chromosomal study as well, not only the BCR-ABL. And perhaps we need the randomized trial to get really the commonest chromosomal and also the importance of choosing the treatment based on that in near future.
Okay. There's another question also. They say that if you use pembrolizumab to increase the MRD or getting the patient into a complete molecular response or undetectable minimal residual disease, do you think it will be cost effective because it's expensive drug and because now the guideline says as long as you have more than 4 log reduction or 4.5 or undetectable, you can proceed with treatment-free remission. Why use such an expensive medication just to get them into an undetectable MRD, to get them into TFR? Do you think it will be cost effective overall or may not make much of a difference? Does the abstract answer some of these questions or no? What's your opinion on this?
No, actually, this was just started and it's a phase 1 based on the animal study. And we all know it shows a great effect in refractory and relapsed Hodgkin. So they just try it to reach into a shorter time regarding the undetectable MRD, and also to give a longer duration of the TFR. Is it like cost effectiveness? I totally agree with you, Dr. Naeem, or with the one who asked that question. Besides the cost effectiveness, also we have to think about the side effect of it regarding the hepatitis, pneumonitis, bone marrow suppression. So this is still early in the study and we're waiting for the result to answer that question.
Okay. There are 2 more questions, Amal, regarding your presentations. The one question they asked, although you didn't, this was not part of your presentation, but they say, is there any role of asciminib in ITP? I don't know how to answer this question. Do you know of any role of asciminib in ITP?
No, I don't know. And I think the mechanism is different.
Yeah.
Yeah, no, I have no idea.
Yeah, okay. So there's another question from Dr. Ghada. She asking, is there any TFR guidelines for different TKIs? I know there is already published that on the 2nd generation TKIs, maybe the time does not have to be like 5 or 6 years of continuous. After 4 years of use, as long as there are 2 years of deep molecular response or undetectable. But any abstract did you pass by? Were they recommending a different TFR guidelines at this stage, or anything that passed by in your review of the abstracts? Was there anything mentioned about different guidelines for different TKIs?
NCCN guideline, they mention regarding like the age more than 18, those who have still in chronic phase with no previous history of accelerated or plus crisis, also those who achieve deep molecular response over 2 years. So that's mainly in the NCCN guideline. As you know, there are different, like the criteria for TFR is different in different studies with TKI, and also the required time of deep molecular response. So,
yeah, I agree. And the NCCN actually does mention some difference between somebody who was on the first upfront 2nd generation TKIs. The time period is a bit shorter as compared to patients who have started imatinib. So that point well taken. So we'll move to, there's some questions on lymphoma from Dr. Damlaj. Anything on, the question, this abstract number 123, the ibrutinib and venetoclax in the first line CLL. And looking at the TFR rate, which is, looks like a good response. Do you think it can be first line for all patients if this shows up like even for mutated patients, the question is that if this combination and time-limited combination may replace the chemotherapy altogether, they need your opinion on this. Any question, any opinion on this thing?
Yeah, I think this is, can you hear me, Dr. Naeem?
Yes, yeah. Very
Yeah,
well.
this is a very interesting point, and I think this is where the treatment in CLL is going to evolve. Currently, we have two treatment options, the so-called time-limited treatment options, either venetoclax ibrutinib or venetoclax with the anti-CD20, so obinutuzumab classically, but also to some extent extrapolation, we can say rituximab. And what's going to really dictate this is the longer follow-up that we see with the MRD conversion. So we know that the MRD negativity is quite high with both of these two approaches. But the question is how much of those patients is going to be sustained. Now, the 5-year update from the Murano told us that probably around half of those patients are going to have sustained MRD at the 5-year mark. And I think that's very interesting. So if we're going to see something similar in the frontline setting, or hopefully even better than in the relapse refractory, you expect a worse outcome. So if we see something like this or better, I think this is really going to change the way we treat CLL. So we are already moving away from chemotherapy type combinations to targeted treatments. But I think obinutuzumab with venetoclax or venetoclax ibrutinib, both are potentially going to change, with a time-limited approach is going to change the way we treat CLL.
Point well taken. I think this is even the long-term follow-up on the Murano as well as these new trials. I think this is shifting the whole concept of the patients of CLL, just like we treated patients with chronic myeloid leukemia with the TFR. I think this will be interesting to see over the next few years how these data with this combination of these new targets of the BTK as well as the BCL2 inhibitors combinations. So hopefully, I think you're right, we're moving into that direction. So coming to the abstract number 472, there's a question, the Nivo and brentuximab vedotin consolidation in high-risk relapsed refractory classical Hodgkin's lymphoma. Where do we stand? They ask a question. I mean, currently they completed 16 doses of brentuximab post stem cell transplant for somebody who goes through auto stem cell transplant for high-risk lymphoma. Do you think this abstract of the study would push you to add nivolumab also?
So, to begin with, we always ask the question, do we really need to give 16 cycles of brentuximab? We treated a large number of patients locally and at National Guard, and we try to go with that, but we see side effects, neutropenia, neuropathy, etc. So it's not easy to administer, and also patients try to get fed up. They get fed up from the treatment of 1 year, essentially, post-autologous transplant. So generally, it's gives us promising remissions, but it's not always straightforward to give. I think what this trial reflected is a more contemporary cohort of patients, where now when we get patients with Hodgkin's to transplant, it's very rare to see someone who's brentuximab naive or nivolumab naive. So this reflects more what we are seeing in clinical practice. And it also tells us that giving brentuximab consolidation is feasible, and we can still have sustained remissions post-transplant. I think the main advantage from this, so number one, the PFS rate is very impressive. You can obviously criticize the study, and you can say that the follow-up was relatively shorter, the cohort size was small. And so these are the criticisms for this study. But I think the main advantage is, number one, is that the PFS rate was really impressive. Number two, the treatment duration is shorter. Even though half of those patients received rituximab or checkpoint inhibitors before, now you're committing these patients to 6 months compared to 12 months of treatment post-transplant. So I think, and this also reflects in terms of the indications for consolidation, it reflects more real practice, where when we see patients that are proceeding to transplant with residual disease, even though typically they did not meet the criteria for the Athera trial, we still give them consolidation post-transplant.
Yeah.
So I think this builds up on the Athera trial result in a favorable way, and hopefully it may convince people to shift that way.
So let's move to the next question. So I think you're right. After the Athera trial, it's difficult not to give with such an excellent response. So brentuximab has become like a standard post-auto also, because based on the previous outcomes. So the next question would be, in the high-dose methotrexate, they asked if there is no change in the CNS relapse despite a high-risk IPI or the considerations that we use currently for high-dose methotrexate along with R-CHOP on cycle 2, 4, or 6. This is a very important study. So this will actually change the practice to some extent. But this is a retrospective analysis from large cohort. So what's your opinion on this one? The question is, what do you see this? Would this be enough to consider not using high-dose methotrexate, because we do see a lot of renal toxicities on some of these young patients, even not only the elderly population, but also the younger portion.
Yes, I agree. I mean, giving high-dose methotrexate with R-CHOP is not easy, especially if you're giving them back to essentially in between the cycles. So some centers defer to use high-dose methotrexate towards the end of R-CHOP. But I think we are seeing lately in the last 5 years, we saw more and more reports, retrospective mainly, from different centers giving us the same message. But pertaining to this particular abstract, I think there are two important points that I would like to know, either from the oral or hopefully when the paper gets published. The first one, keep in mind that the indication for high-dose methotrexate changed over time. So the original high LDH and extranodal site of disease, this I think that doesn't reflect contemporary practice. So I'm more interested in the second cohort of patients that they reported. So these are the ones with high CNS IPI and the ones with testicular involvement. So specifically, if they did a subgroup on this, are we going to see a reduction in the CNS relapse? So I think this is...
So we'll have to look at the subgroup analysis also. On,
exactly, and the final paper when it comes out. So I think this, I'm not sure that this is, we're ready to accept this as it is. I think we need more information from this, but this is an important analysis.
Especially the subgroup analysis. Okay, so another question, the last question from the lymphoma presentation is that, do you think the venetoclax with R-CHOP has shown more toxicity? Would that ask or make the researchers think of like changing the R-CHOP components to reduce the toxicity? If you want to add venetoclax, would you consider changing some of the components of the R-CHOP? That's what the question is. Is this going to lead to that?
Sure. So this, I think this refers to the Cavalli study when they added venetoclax to a backbone of R-CHOP, and the hematologic toxicity was the main issue. I have to admit though, the responses that were seen were not very, very impressive. So I'm not sure that this by itself is going to be practice changing in a way similar to the Phoenix trial where ibrutinib was added to R-CHOP. The main question is, I think it's very difficult to just remove one of the R-CHOP components without doing a proper assessment of this. So I think it's going to be either R-CHOP stays as it is, or you add on the venetoclax or ibrutinib with the expectation of the hematologic toxicity with supportive growth factors and the like. So I think it's just going to be an add-on.
Unless also somebody has to really look into the prospective in a randomized fashion and see with the same number of patients to see what the efficacy, toxicity, as well as the outcome, progression-free survival.
Exactly.
Patients. Okay. So let's move to the abstracts for stem cell transplant. So the interesting thing that was shown, Dr. Zayed, was that the Thiotepa-based conditioning, apparently, we tend to use beam conditioning, but for primary CNS lymphoma, the Thiotepa has significantly shown a better outcome from the CIBMTL analysis. So in your opinion, do you think it should completely replace all other kind of conditioning, including the TBI-based conditioning, sometimes that people tend to use?
That's very excellent question. The first thing that the beam should be discouraged from all, because none of them have CNS penetration. The Thiotepa has very significant CNS penetration, so it is being comparable to the radiation. So there is also some retrospective data, but comparing Thiotepa versus TBI, and there is comparison that it is equal efficacy. So the radiation-free, the use of Thiotepa is very encouraging with either both type, the Thiotepa biosulfan cyclophosphamide or Thiotepa carmazine alone. That will be very encouraging and it will be the standard of care for those patients with primary CNS lymphoma.
Okay. There's another question now. The Philadelphia positive ALL, the one that you presented, the BMT versus no BMT, bone marrow transplant for patients who achieve a complete molecular response. This is like, for example, like an LBMT. Where do you, the question is, where do you see the auto stem cell transplant if the patients achieve they're not considering the allo transplant, but for these patients who are in complete molecular response, would you consider an auto transplant versus continuation of treatment with TKIs plus minus chemotherapy?
Excellent question. That it will be very important question to be asked. I was expecting this question, but the use of auto has been used for a patient that he achieved complete molecular response, and their outcome is excellent. So it need to be seen and a prospective trial rather than just really retrospective data. We are waiting the transplant versus non-transplant if it's been done, and the outcome of these data for those patients, they achieve molecular response by 3 months. That will be the final judgment for those patients in Philadelphia. Did we need to go for transplant or just to go with the chemotherapy alone with TKI?
Okay. So I think most of these questions are actually over other questions just now. But I think that is basically what they're saying is thank you, and it was excellent discussion, excellent speakers.
Okay, so thanks a lot. We can conclude. Thanks a lot.
So I'll hand over to you, Amal, to please to close the meeting, and yes, thank you very much for this invitation to us.
Thanks everybody actually for this great attendance and participation. Thanks for our speakers, chairperson, attendees, for your time, staying late on Friday. It was really great having all of you with us. It was really challenging. Thanks for our sponsoring company, Johnson Platinum, Sanofi, Takeda, and Amgen as a silver sponsor. Thanks for the organizing company, Casadius Lane, for organizing this meeting, helping to setting all these platform and designs. I would like to request you again, if you don't mind, if you can visit the platform and upload your photo, so we'll keep it for the memories and we can show it next year, inshallah. So the platform will stay for another 2 days. If you don't mind, there is also a booth where you submit your evaluation in the platform as well. So please submit your survey and suggestion as well. I hope for everybody to enjoy this year 60-second ASH as a virtual experience. Stay safe and have a good night. Thank you.
Thank you very much.